sir.
Yes, sir. Now can see.
Hello.
Yes, sir. Now can see the slide, sir.
Now things appear to. Can you see the slides?
Yes, sir. Sir, go to the slideshow. Bimal sir, can you go to the slideshow?
Yeah. Can you see the slides?
Yes, sir. I can see the slide, sir.
Okay. Define cardiogenic shock, friends.
Sir, this is not the slideshow, sir. Yeah. Now, sir, you may continue.
Yeah. Can you? Yes. So I have now chat box open. Earlier chat box. So can you give me the definition of cardiogenic shock, dear friends? Okay now. Okay, great. I can see. Okay. So one has to have systolic blood pressure 90 with decreased cardiac interest and increased or normal. Very beautiful. So this is how you define, and along with it, you should have evidence of end organ hypoperfusion, which can be evidenced by, for example, decrease in urine output, or for that matter, decrease in the mental status, which was earlier okay. So, what is the role of impella? How do you people think that impella, is effective? What is the mechanism of action? See, all these questions will be in the DNB exam will be asked next time. Next on 20th and 27th, we have planned that three students each will be also participating as panelists, sort of, and they will be speaking also, along with two of my senior colleagues. So we'll be asking questions straight away, and they'll be answering on mic. I mean, rather than typing. Nevertheless, so what is the mechanism of impella? I mean, what do you think is the? Doesn't matter if you give a wrong answer, because this is how your exam goes actually. You are supposed to write in one line only. I mean, one or two lines, not more than that. Pumping blood to aorta and bypass LV. Great. So everybody pump the and for right ventricular also, there is impella RP also, which is for right ventricle. And beautiful. I am very happy to know this. Note this answer from your side. Now tell me one thing. What do you think is the increase in the cardiac output? So there is a okay, actively pumping. So what happens is that LV is obviously under and not working, either because of the acute myocardial infarction situation, which is a common situation for this thing, or you expect then when we are doing angioplasty, like in this case, rota and all that, you expect there will be no flow, patient has severe LV dysfunction, patient will go into pulmonary edema, and then you will be managing the pulmonary edema, you will not be able to do the procedure. So cardiac output increases. So it increases, as rightly said, by 2 point this thing. Yes. So this is about the definition. And what happens is, as it is a basically, you can say, catheter based miniaturized ventricular assist device. So earlier devices which went through, which are still available, earlier versions are good to go with 14 French. Normally we do angioplasty with 7 French or 8 French, 7 French check flow into the sheath. Here you require 14 French. So on the long term or the intermediate term, I mean 4-5 days, limb ischemia is a major concern. Previous slide, sir. You want to see the previous slide? This one? Okay. So most common, as I said, are acute MI, and initially the only thing is cost is an issue. Cost is an issue. As you can see, the other IABP costs only $1,000 or 50-60,000 rupees total, because balloon costs 45,000, impella cost 22,000. This is how we go about it. So this you go through the femoral route, you put the catheter, you retrogradely cross the aortic valve and put your impeller. The inlet is over here, as we'll see later, in the left ventricle, and outlet is in the proximal aorta, as people have rightly said. People will ask you in the question, what are the other modes of by which you can give support. IABP, Impella, tandem heart, and venous arterial ECMO is the way to go. Important question which may be asked is, if patient is also having decreased oxygenation, then the Impella or IABP will provide only cardiac output support. If you want to do oxygen support also, oxygenation is also on the lower side despite all your measures, then ECMO is the way to go. उसका मैं भी जाके कर लूँ, ठीक. Then ECMO is the way to go, where you require both oxygenation as well as this thing. As we said, so this is how it acts. Basically, cardiac output is increased by about 2 to 2.5 liters with the earlier devices, and the newer devices which require bigger bore catheter can increase cardiac output by 4.5 to 5 liters also. And obviously, when the two important things happen. One is cardiac output increases. Secondly, the left ventricular wall stress decreases. And which is the main issue over here. So LVDP decreases, left ventricular diastolic volume decrease, which decrease the pressure from outside in the coronaries, such that coronary perfusion also increases. So it also not only provides support, it also increases the recovery of the left ventricle. Okay, this we have already discussed. So I was talking to you about the Impella CP, they call it. CP means cardiac power. That's the full form. There are newer ones, Impella LD, that is left direct, and left percutaneous. One can go directly through aorta, or that is called as direct. So this thing, there is a called as RP, right power, that is for right heart also. So you have to know this thing. The full form CP, Impella CP was the earlier version, giving up to 2 or 2.5 liters, and this one is the newer one, LD. Okay, so here it shows it again, that over here is the inflow, and it goes through this area remains at the aortic valve. Okay, okay. So this is all about the Impella. So this fellow is a relatively, middle-aged gentleman, or young gentleman, and he has presented with syncope, and he was detected to have ventricular tachycardia, which was hemodynamically compromising. Why they can be ventricular tachycardia hemodynamically compromising, as well as it can be, if rate is less than 200, then patient may be, hemodynamically not that much compromised. So once it is above 200, then, patient will go into shock and all. Typically, sinus tachycardia, for your information, typically sinus tachycardia, can anybody tell me? Sinus tachycardia, don't write the short forms, kindly write the full form, MAD. You have written, if you, I'll be, happy if you write the full form. And while you are writing, tell me what is the maximum sinus heart rate? I mean, you let a person run in front of a lion, and his heart rate is likely to go up. So how much it can go up physiologically? Okay, actually this is a new kind of 220 minus age, yes. So it will be somebody mentioned 180, so around 170 or so, maybe even 180, it's fine. So obviously it will be different for males and females. Importantly, females tend to have higher heart rates at lower exercise, predominantly because of deconditioning. You have athletes who maintain, because cardiac output is heart rate into stroke volume. If you increase the stroke volume, their heart rate will not increase. Nevertheless, the question was around, the answer is 170 or so. So what is this? Have you typed the full form? My computer is okay, but this is new. So I have to check what's the, okay. So otherwise, ARVD. Okay. So patient is very beautiful. So you have some sort of mitral valve prolapse. Beautiful, beautiful. I like it. Mitral valve prolapse, mitral annular disjunction. Beautiful. I mean, who has answered it? I mean, I think the fellow needs full marks. Reason being that this is a relatively, I mean, newly recognized entity. Nevertheless, as rightly pointed out by the previous person who answered, I mean, ARVD and all that, you have a battery of things which you have to rule out. You have to rule out channelopathies, you have to rule out ARVD, you have to rule out hypertrophic cardiomyopathy, and of course, you have to rule out coronary artery disease, and then you come to rarer causes like mitral anode dysfunction. In this person, over here, you see the right ventricle. If you can see my marker, right ventricle does not appear to be dilated, but in certain ARVD cases, especially in the earlier ones, fatty fibrofatty infiltration is actually diffuse. Actually, I mean, it is sort of fibrofatty infiltration is sort of patchy. So you may not have that much dilatation. There may be aneurysm in some part of the RV, the other parts may be normal. So mitral valvular, how do you define it? Beautifully answered. Can you tell me what is the definition? What is the problem? I mean, I'm sure this term will be new to many of our dear colleagues and students. Can you tell me what is this quickly? We have already wasted a few moments. Okay, it's only 7. We have still half an hour, 40 minutes to go. No problem. But I want you people to answer, because if you answer wrongly, and get the correct answer, then you remember more. Otherwise, you read through so many things. I read so many things. We tend to forget. Okay, this chat box is not doing some. इसको नीचे लाते हैं, इसको नीचे करते हैं, बड़ा नहीं हो रहा है. Okay, gap between mitral valve and LV replaced by fibrosis. So beautifully said, more or less. I mean, separation. Beautiful. So mitral annulus, and there is separation between. I'm happy that a lot of you know about this condition. Uh, you have to see the insertion line, and this is not the correct view. There are other technologies like MRI, etc., which can be used to find it. But here, perhaps you can see over here that it's not okay. So there is a gap between the insertion of the mitral valve leaflets, which is the exact location of the mitral annulus, and the start of the ventricular muscles. Okay, just a second. So, rightly said. So, this is a important now recognized cause of malignant ventricular arrhythmias, as you people mentioned. Okay. Actually, my computer, the original one, I don't trade me. So we were okay. I will have to share again. It seems. So what, as I was telling you, so as you also said, so it's a structural abnormality, and this is the area. This is how it looks like. So you have to take a proper view and uh, see it. So it has been classified also. Basically, what happens is if it's less than 5 millimeter or more than 5 millimeter, and typically it is associated with myxomatous mitral valve disease and mitral valve prolapse. I will not go into, and you should be able to see this hinge point and a start of ventricular myocardium more than 5 millimeter. There should be gap both in systole and diastole. Okay, and you can do MRI and all, see it. Now this is a fresh case. I mean, this is another one. So this fellow, presented with what? Chest pain. So what is the diagnosis? What is the diagnosis? This is a very simple, clean, simple case. I mean, many a times they will not, you will not always be shown very difficult cases. I mean, something which is, for the textbooks picture kind of thing. Okay. Pericarditis. Why do you say pericarditis? See, you see, okay. PR depression. See, there should be diffuse PR depression, but I cannot see too much of PR depression. You can keep it as a possibility, okay, but I'll be more inclined. There is a pen. Okay, beautiful. So this is fellow is a he has all many risk factors, and this presented there is a, as you said, this is a somebody said pen. So agreed on that part, but to not 100% because there is no ST elevation of the AVR. So you have to see that. ST elevation in the AVR will perhaps suggest something like left main or very proximal or osteal occlusion. Okay. So you have ST elevation in all the anterior leads as well anterior. This distal LED occlusion. No, dear friend, this is cannot be distal. See, myocardial damage is dependent on the site of occlusion. In a patient who has distal LED occlusion, I'm happy for that fellow compared to somebody who has proximal occlusion because the myocardial supplied by the distal area will be much less. So obviously there'll be damage, but it will be much less damage. And here, yes, somebody has again beautifully said. So this is a typical case wrap around LED. What is this? There is a classification of LED also, type 1, 2, 3, 4, and this is called as beautiful answer, and this is a correct one. And somebody has rightly said. So this is typically there is involvement of left anterior descending, and this is type 4 LED, which is called as wrap around LED. How do you define it? That is important. The key is very important. So everybody who has not answered, who didn't know, kindly note it down that note this thing is important. More than 25% of the inferior wall is supplied. So typically, some of the surprisingly, this was a case which I did only 2 3 weeks back, and here this was the ECG. The important another the important prognostic is that this is a patient. You see this kind of patient, he needs real angioplasty. Many a times what happens is if you work in a busy center, you may have 2 or 3 MIs. We often have this kind of situation over here at GVPAN. So not all the time, but many times two patients. So this is a fellow who has to be taken in because his two territories are at risk. Nevertheless, so we opened it up, but it was a wrap around kind of situation. But some or the other, maybe there is some microvascular, debris has gone to microvascular circulation. So it is not that big a wrap around, but the ECG surely looks like that. Many a times in clinical cardiology or in otherwise in other medical fields, all things may not be matching 100%. For example, the best example is, for example, if you have a left ventricular hypertrophy on echocardiography, but only about 25-30% there'll be certain like Sokolow-Leon criteria will be fulfilled in only about 25-30%, very less sensitivity. So all things may not go hand in hand, but nevertheless that diagnose this thing. What is this? This is a modified view, and which has been done to look for audio gone. Hello. So what is the diagnosis? Audio okay. Okay, we can hear you. Great. Thank you. Okay. So this is a patent ductus arteriosus. I've given you a hint, but I'm showing you this is a modified view actually. This is a modified view. Over here is the aorta, and over here is what is this? Can you tell? Okay, PDA, patent ductus arteriosus. Okay, PDA is there. So what do you see? What all you see? Do not always jump at the diagnosis. I tell you people all the time, diagnosis, even if you give totally wrong diagnosis, you still get full marks. Everybody, if your findings are correct, you see in exam, we everybody will see. I sit in examiner will see that whether my approach is okay or not. Approach is important because science is vast. You have all your life in front of you to learn. But if your approach is right, you will go the right way. If your approach is wrong, you will never go the right way. So don't jump at diagnosis. What is being given? That is why, many images are not of that, they are not that prominent from showing you point of view, from spotter point of view. But I want to see how you people interpret what is happening in front of you. Okay, tell me one thing. Why this area? This is hazy. This tells you many things actually. Why this is hazy? And I can give you a hint. This is the patent ductus arteriosus area. This is somewhere around, it's a large PD actually, because these markers are 1 centimeter markers. So this is more than 1 centimeter actually. If I rotate this cursor, this is 1 centimeter more than that. And this is the reason why this fellow is in great trouble. Tell me, friends, what is this? Why this is hazy? Give you a hint. Well, we to make it more see, the color flow becomes more prominent if you give certain injection in the. So what we have given. Okay, now you people require lots of hints actually. So yes, beautiful. So it serves many purposes. One is it identifies your structure so beautifully. So unless patient has a atrial septal defect, and that too, which is shunting, I mean, which will be a rare condition, which is shunting like anything, only then you will have such a beautiful opacification. Okay. So this is a touch screen computer. So have to be careful. Okay, saline contrast has been given, and you can see from aorta, I mean, the blood is flowing both ways. So this is a basically hypertensive patent ductus arteriosus. Okay, there is a bidirectional flow across the PDA. Now, I'll personally deliver the gift to the fellow who gives me the correct answer. This is a promise. Wherever you are, either on Earth or on Moon or wherever, if you give the correct answer. This is very classical, very beautiful, one of the rarest of the rare kind of situations, and which I could get hold on to, done at my center only. This is to give you a hint, this is a small baby and sort of newborn baby, I would say. Okay, I mean, see, I told you, see, diagnosis does not interest me that much, because diagnosis, see, once you the problem with diagnosis, once you commit to a diagnosis, then you cannot go back. You cannot give any differential. I say that, for example, I say that patient has I see echo which is showing 20%. I say patient has a severe corneal disease. I should say patient has left ventricular dysfunction. It could be because of corneal disease, it could be because of idiopathic, genetic DCM, and so on. It could be because of so many cardiomyopathies. I mean, end stage hypertrophic cardiomyopathy, and so on. So, I mean, we have to give this thing. So, what do you see? What do you see? See, many of you have given right answer. So my gift offer is off, because that was one for one person, not for everybody. So, but gift offer is still open to the person who tells me what do they see. This is, I tell you, this is 1 centimeter markers. Okay, I told you earlier. Many times people are not the markers over here. If you can see my cursor, 1 centimeter. So this is a very small kind of heart. Everything gets over in 6-7 centimeters from the chest wall, and so this is a very small heart. You can see it. So appearances can be deceptive. However, here the marker, this thing. Past tunnel, long axis view. What do you see actually? Okay, okay. So now, see, I'll tell you. Here you see the bifurcation of the pulmonary artery. Can you see my marker actually? You say yes, if you can see. Okay, so this is the bifurcation. That is how actually you recognize when you see complex congenital heart disease cases. See, I mean, on echo, you diagnose them based on the bifurcation of the pulmonary. Here you see bifurcation. This valve is okay, but because view is such that that's why you are not able to see the pulmonary wall well. However, what you see, and somebody has nicely said that, but still it's incomplete. So aortic short axis, pulmonary artery bifurcation, beautiful, and you see this flow. See, here is the where is the cursor ultrasound probe? Tell me over here where P is written. P is for Philips. This is a brand name they are advertising. So here is the cursor. So anything, any flow toward the cursor is what? Tell me quickly. These are simple things. We all get confused. I get confused all the time. You tell me. Red. Beautiful. So anything away is blue, obviously. And when you get a mosaic greenish pattern, that is means turbulence is there. So this coronary artery, two things are there. This is highly dilated. In a small baby, I expect this coronary to be maybe 1 to 1.5 centimeter. This is left main. And this is, you can see it. So it is dilated. One point, important. Another important point, you have flow away from the coronary. I mean, this is wrong. This is dangerous. Flow should be into the coronary. And here you see there is a blue flow on the right over here. So this is happening. Though this is going in the reverse. Whatever of the left ventricle I can see, I can say that left ventricle does not be that much dilated. I don't know because how do these people present actually? So this is basically L kappa only. Classical L kappa on diagnosed on echocardiography. Of course, we'll have to confirm it. So yes, they typically present with ischemic left ventricular dysfunction because the anterior wall or the anterior part of the left ventricle, how much percentage is contributes to the to overall cardiac output approximately. I mean, this is variable obviously, but approximately how much to the ejection fraction, how much it is contribution of the anterior wall or the area supplied by the left anterior descending coronary artery. About 70% or so. 60 is, I'll perhaps give you marks, but nevertheless, it is a little bit even more. That is why whenever you are sitting in emergency, you have a patient, you see ST elevation in the inferior wall MI. Okay? Patient has CHB or not, doesn't matter. CHB means larger infarct, maybe this thing. But patient has gone into pulmonary edema. Inferior wall MI, classical, ST elevation. However, patient goes into pulmonary edema. What is the diagnosis? Most common. I mean, what are the causes? What could be the causes? Quickly, again, inferior wall MI patient present with pulmonary edema. You do not expect an inferior wall MI patient to have pulmonary edema, even in dominant RCA. Even in dominant RCA, you will not. You should not have pulmonary edema because the area supplied is okay. Beautifully, you have said MR. Okay, what more? One more. Triple vessel disease was beautiful, very good. I like it. Okay, so triple vessel patient is likely to. So what it means? Whenever you are saying, so you take the consent even more aggressively that this fellow can die soon. So you take consent, be aggressive. Is be treated more aggressively and so on. So papillary muscle rupture and so on. And I recently did a case of inferior alumni, and I will show you that spotter later on. We'll publish it as a case report soon once the fellow gets surgery. The patient has a rupture of the inferior wall. Most of the ruptures will, inferior wall ruptures are not uncommon also. Nevertheless, he has a pseudorism of the left ventricle. We took a, I'll show you maybe sometime soon. Okay, beautiful. So this is a young girl, and she has presented with distance. Nothing extraordinary about the patient. I mean, technically, I mean, somebody has taken. I don't know how you people do in your lab. We do it in reverse. Here, the past tunnel long axis view. We have mitral valve on the left side. This fellow has on the right side. Uh, though this is from my left lab, but some of my colleagues has done it. Nevertheless, what do you see quickly? I mean, it shows two important things. This lady otherwise is fine. She says, I get breathless. VSD with aortic valve prolapse. Okay, great. Now, I give you almost full marks, but you get total 100 out of 100 if you tell me more. Subaortic membrane, beautiful. So whenever you have exam, I'll suggest that 4 or 5 of you form a group and give exam in combination. You'll get 100 out of 100. Okay, so basically what happens is, so when you have a subaortic membrane, all the hemodynamics across the aortic wall are totally disrupted. In these patients, typically the aortic valve at birth is absolutely normal, absolutely normal. So, however, because of this flow turbulence, the thing get the this gets gets damaged, and that is when you have this kind of eccentric kind of aortic regurgitation, which you have rightly pointed out. What is the most common abnormality associated with subaortic membrane? Congenital. It's a congenital heart disease, obviously. This membrane has not grown. AR is obviously, AR can, see, AR is a, later on developed. It's a derived kind of situation. You can have coarctation of aorta, can many of things can be there, of course. So VSD is a one of the almost 80 to 90% people can have VSD. Okay, 80 to 90% of the patients can have VSD. And this is what is seen, and many a times this VSD is restrictive only. That's why tell me one thing. Based on this echo, I mean, you should be able to. The idea of this, all this thing is not to get you a diagnosis. Make a diagnosis. I show you the picture in reverse. You will again be confused. If you go by the findings, you get you when once the picture is there, get the maximum amount of information. Tell me, I say that this patient is likely also have pulmonary artery hypertension. Is it? Can it be so? Can this fellow have this girl have pulmonary? Quickly answer yes or no, and not. Why not? No. Very good. Why? Based on this echo, it's a restrictive ESG. Yes, and yes. I mean, restrictive patient can have. See, LVOT obstruction. The thing is, here you see the right ventricle over here, my friends. Beautiful. Right ventricle size and contractile looks okay. So I don't want you to see on in one area. You should not have a tube vision. You should have a broader vision. Keep everything open. Keep everything open. You see aortic degradation, and you see we have diagnosed the whole situation. So there is a lot. These images are very, very, and this has been this AR. Can you see in a case like this? Patient can even present with infective endocarditis. Wherever there is a turbulence, they can be IE. Agreed? So, slide. I'm not moving any slide, my dear friend. So that's why they are not moving. Okay. So can this be because of infective endocarditis? I say this is acute AR. Patient has 2 day history of fever also, which prompted her to visit the physician. Of course, you will have to do this thing. Is it a chronic AR or acute AR? See, it's obviously a chronic AR. Reason being, no, this is not acute AR. Reason being, you see the left atrium. Left atrium is a telescope to the heart. If you have to see one chamber in the heart, if you tell me you I will show you only one chamber. One chamber. I will which chamber you do decide to see? I will say left atrium. Nothing else. Left atrium is a telescope to the heart because left atrium is dilated. It's a suggestive of chronic disease, myocardial disease, typically of the left ventricle and for that matter of the to some extent right ventricle also, because many of these pathologies are combined. So left ventricle here is markedly dilated. These are 1 centimeter. This should be somewhere around 4 to 4.5 4 centimeters. So you have to see the whole picture. That's more important. What is this? What is this? What is this used for quickly? So we have 74 great students over here. 74, that's a big number. My friend, 74 is a big number. I mean, you should be answering like anything. Good. See, you have to give correct answer, my friends. It's a PFO closure device. Nice is that. What is the difference? What is the difference between two? Quickly. See, this please go and read all these spotters. Note down their names, whatever spotter, L kappa, and this thing, and all subaortic membrane. Read only, open the Google, type it, and read 10 lines each. Beautiful, beautiful. You know all these answers, but you don't tell me. You don't want to tell me the right answer. It's okay. So the disk is this is smaller. So that is the key. So this is a simple one. I'll move on to next one. If you tell me this fellow has a anti-volume and so this is a VSD, but my only concern with this kind of typically in these patients the septal defect is serpiginous. It is not a clear cut punch out hole like you do from a puncher kind of paper puncher, whatever you call it. So can you see how diffuse it is? So many of these defects, because they are through a friable, damaged, disrupted myocardium, so they are serpiginous kind of defects. So you get this kind of beautiful picture. Keep this in mind. So beautifully said, three distinct jets. So you see multiple jets. It is not a clear cut, but you see a muscular congenital VSD, you have a beautiful punched out hole. So that's how, I mean, these are small things, finer things. You people are, I'm sure, reading and seeing lots of cases at your respective great institutions. But what I want to, you people to become is to become stars. You have to do the best, not good, but best. So this is how it is. Okay, so this is like this. Okay, this is another patient which is similar to the previous one which we saw. And should I move ahead and leave this one? This is another fellow. No, systolic anterior motion. Okay. Okay, now that's you have asked, what is the best way to, this is not SM actually. See, as a general rule, beautiful. Somebody is rightly saying, yeah, two, three things are important. In hypertrophic cardiomyopathy, you will extremely rarely see any aortic regurgitation. If at all it is there, it will be very, very, minimal kind of. Here you find vena contracta, which is almost covering whole of anything more than zero point 0.6 or so will be, sensitive of severe AR. So this fellow is real. So the acute or chronic once again. I can say there are certain things. It is also a diagnosis based on uh, echo. I will strongly suspect but history is not there with me, unfortunately. Nevertheless, there is subaortic membrane also. Acute or chronic? Tell me why quickly. See, we saw a spot of subaortic membrane two spotters back, and you people are still a little confused. Some of you at least are. So we have to know this is a chronic disease actually. Patient likely has aortic stenosis also. Aortic valve is totally, this thing. Maybe it is infected, but surely. So beautiful. So LA dilatation is there as we discuss nicely. Not that beautifully seen, but it can be obviously seen. How here image is smaller. See, this is 1 centimeter. 1, 2, 3, 4. It is at least 4 centimeter. But importantly, the left ventricular muscles is enlarged. I mean, it is thickened. This is a chronic process which has been going on, which has been interrupted and perhaps accelerated, likely because of intracranial endocarditis. For that, we have to have history. Okay, this fellow is a newborn baby. We saw one or two newborn babies earlier. This is another newborn baby which has come to us. And this saturation was only 60%. Patient was doomed, and this was only 12 hours post birth. And they gave some injection. Patient improved, and when they stopped the injection, patient was deteriorating. So, okay, beautiful. Slide not moving. Okay, we'll move the slide. So, this is period stenting. So, this is typically done where the circulation is ductus dependent. Like in this case, diagnosis of pulmonary atresia with intact ventricular septum. So maybe I should have kept it down it. So what is this? Then we move, and after that we'll end our in 2 minutes. What is this? Can you see the slide? If yes, pneumopericardium, correct. Beautiful. Have a look at the thing. And what is this? Many a times I can tell you one thing. In many of your exams, examiners will show you a image, X-ray image, or maybe some fluoro image, which may be running, and they will show you, it will have 2 or 3 things in it. Some stent, some device, some, some sort of, like I showed you first one. So what is this? This is a ICD. Why it is a ICD? Quickly, yeah. Okay, left hand. Okay, ICD. Coil, beautiful. You see coils over here and over here. Beautiful. Full butter, full marks. Very good. I like it. And this is perhaps the last one I want to show you more, but unfortunately, my computer at the last moment got messed up. This is a alternate computer. This is a very, very beautiful one. People, if an examiner has it, they will show it to you. Okay, balloon atrial septostomy. Beautiful. What is this balloon called? $1 million question. TJ, somebody has also already given an answer which I was about to ask. In our balloon. No, dear friend, this is a balloon with a marker. This is not in our balloon. In our balloon, I will show you maybe once again in this thing. Fogati balloon. Okay, no. In our balloon has a central waist. It's a self-centering device. It's a beautiful device. It first inflates, in our balloon inflates in the distal part, then with increasing pressure inflates in the distal part because of the different braiding of the two parts. And it is the tightest Rashkin balloon. Good. Okay, let me check. Now, after one answer, everybody is writing Rashkin. So nice. Reason I like it because once you type it, you will never forget it. Type, everybody type. If I want to see 74 rash kids over here. Nevertheless, so rightly answered. So maybe we will. This is last one. I wanted to show you some other ones, but I think we have covered many of them. Last one quickly, and then we end it. Don't go by the diagnosis. Diagnosis doesn't matter. It will come automatically. Your approach has to be perfect. CTGA, DTA doesn't matter. What is happening over here? I can tell you one thing over here, seeing over here on the left hand of the picture, if my marker can be seen, normally you do not see septum in over here. Here you can see interventricular septum. Septum is typically seen in the LO or iliocranial view. Once you see over here, this is one of the conditions where both ventricles are lying side by side, and you see over here in the PA view. So you see both ventricles. So it's a pigtail catheter going into which kind of ventricle? You divide the ventricle into trabeculated and non-trabeculated. My throat is like my computer, my throat is also messed up because of severe URI. Nevertheless, so this is a trabeculated ventricle going through a retrograde, I mean retrogradely entered. So this is, and this ventricle is supplying the, so obviously this is going through the aorta. And here this is supplying the pulmonary artery, the smooth ventricle. And what is important is you see over here the pulmonary valve. Normally, as I've told you many times, perhaps earlier on, that valves are not easily seen. Here you see beautifully. Focus over here. You can see my marker on the right hand screen. The valve is not opening. It is doming actually. So this is with pulmonary stenosis also. So femoral artery, aorta, right ventricle. That was the catheter course or pigtail. The other catheter was NIH. NIH is a catheter which is the distally, it is blocked. I mean, there is no end hole to it. So it went to femoral vein, IVC, and atria, and this thing. You see, it is going straight on the right side. IVC is always on the right side, aorta on the left side. They can be looping, can be different. They can be right arch, left arch, but this is always on the right side and left side. That's how you see it. So it is going straight and coming like that. Okay. So this is AVVA discordance. Okay, and you somebody said posterior dilatation. Let me check. Yes. So there is a posterior dilatation also. The importance of posterior dilatation is that you do not see posterior dilatation in a patient who has infundibular PSP dominantly, like for example TOF. You do not see any dilatation. But when you have predominantly valvular, I'll be taking a talk on BPV also sometime later. Nevertheless, this is a very pliable, beautiful valve. And the endless. So post-nodal dilatation, one of the marker that valve is not dysplastic. So these valves, not in this case, but otherwise they are very much openable. So with that, I wanted to show you something like integrated backscatter or something. Okay, we'll stop here actually with that. And with that, we will end over here and stop sharing. I'll stop sharing. We have had a few of these spotters. Okay, I hope you people loved it.